121 people. Amazing. Sorry for keeping you guys waiting. I had an instance where my cat didn't put me out. Anyway, we're here now. Thank you to everyone that has registered. It's great to have so many people in our industry who are interested in this subject and interested in Dentacare's event. I've got Rena up there in the corner. Rena will be coming on in just a moment. I won't keep you guys too long, but I just wanted you to introduce you to Dentacare because we are sponsoring the event, and you might not have heard of us, so I think it's important that we introduce ourselves. So about your host, so that's me. So my name's Laura Bailey. My background is actually in dental hygiene and therapy. So I graduated from Manchester University about 5 years ago, I think it was, and worked in private and NHS practice, like we all do when we start, but really found a passion for oral hygiene and prevention, and just finding out how to motivate the patient and improving compliance. So from hygiene, I've had a little bit of a break from clinical, and I've been working with Dentacare as a clinical business development manager. And this basically means that I just help advise them on, what the profession wants, what would help us, and actually what products are clinically efficacious and work. So, who are Dentacare? So Dentacare have actually been around for about 26 years, but we're a very small company. I think we're about 25 or 26. So that might be why you haven't heard of us. But we do actually work with a lot of practices and corporates. And what we do is we basically specialize in oral hygiene products. So that means that we don't create products ourselves, but we source really high efficacy products, products that really work and we believe in, and most of them aren't available in retail. So it's all about creating that bespoke treatment for the patient and to improve compliance. We really are passionate about oral hygiene, and we believe it should be the cornerstone of all dental treatment. So what we do is we work with practices on improving the patient journey in providing bespoke oral hygiene products. And yeah, we just help improve the treatment. So, if you have better treatment, you're going to have better results, you're going to have happier patients. Just before we dive into the main event, I'd like to just talk about Chlorhexidine, mainly because the work I do, I get to hear a lot about what the profession wants and the topics that are very important at the moment, and one of them is Chlorhexidine. So I know that a lot of clinicians are moving away from Chlorhexidine, and I can understand all the points. But I was in Barcelona about 3 weeks ago, and actually I went to this amazing laboratory with a company called Dentate, and that's actually one of the companies we work with, and we source a lot of their products. And I saw some amazing research that was done on Chlorhexidine and how it works, its mode of action, and how we can basically ascertain the best Chlorhexidine solution, and how we can use it with our patients. I mean, the key thing really to say is that chemical adjuncts are exactly that. They're an adjunctive therapy. They shouldn't be used willy-nilly. And if we can get oral sepsis and healing and reattachment of the periodontal ligament without chemical adjuncts, then that's amazing. That's perfect. So mechanical cleaning really is key. They're just an extra help. But in terms of like the gold standard for antiseptics, Chlorhexidine is that. I'm not going to keep you too long, guys. So there's lots of cons to Chlorhexidine. One of them is staining. I'm sure there's lots of hygienists on here and GDPs that just get so frustrated when patients go into the shop and buy Chlorhexidine and they end up with staining, it's just doing exactly what we don't want. We want a nice clean surface. We don't want a porous, rough surface where bacteria can just attach to. So yeah, staining's bad. Microbial resistance, so we're getting long-term use when we shouldn't. The higher the concentration of Chlorhexidine, you get a bitter taste. You can get an altered sense of taste of foods, and that can actually carry on after the use of Chlorhexidine for a couple of weeks. And also, not every chlorhexidine solution is the same. So this is something I learned when I went to Barcelona, is that you might have 3 mouthwashes or solutions in front of you, and they'll all be the same concentration of chlorhexidine, but each one of them will work and be completely different in terms of the efficacy. So you might have one that is very poor at killing bacteria and one that's very good, and it completely ranges. And it can be to do with the pH, the bioavailability of the molecule, and it's actually really interesting to delve into it. It's not just a mouthwash. Obviously, the pros: it's a very good antiseptic, has a wide bactericidal effect, and it's good for high-risk patients and patients you're not getting that result from. This is us. This is some of the team, the management team in Barcelona, just so you can get to know our faces. This is the research centre. So I've got just a couple more slides. I just think it's important that when we're advising patients on products, we really understand what goes into them and how they work, because it's important to educate your patient. So when we look at chlorhexidine mouthwash, for example, there's 2 things that we need to take into consideration. It's the spectrum of activity. So how much bacteria does it kill? So does it kill fungi? Does it kill viruses? Are we going to achieve the oral sepsis that we want? Because if we're not, there really isn't any point, because we're just going to get all the side effects with none of the pros. And the other thing is substantivity. So yeah, we've killed all the bacteria, but how long does it keep the bacteria away? Because if we kill the bacteria and then 3 minutes later it's all colonizing again, then kind of what's the point? So that's all about the bioavailability. So one of our products, we are an oral products company, is called Perioade, and this is from those partners, Dentaid in Spain. And we've got lots of studies that basically compare your 0.2% chlorhexidine and your 0.2 with ADS, which is anti-discoloration. And it compares Perioade, which is actually 40% less chlorhexidine, but it's combined with 0.05 CPC, which is antiseptic. And it actually is more effective, even though it's a lesser chlorhexidine at killing bacteria, in comparison to the 2 market leaders. So that's the spectrum activity. The other thing was the substantivity. And we've got various other studies. This is one in particular, and this shows that even after 12 hours, Perioade is effective up to 96%. So we talk about the healing process and keeping that bacteria at bay. The longer it's away, really, the less toxins that release, the less inflammatory response we get. So that's really what we're looking for in a chlorhexidine mouthwash. So this is the Perioade range. This is the intensive care. So this is for short-term use. That's 0.12 with 0.05. And that's, your implant treatments, your peri treatments, maybe where the patient isn't as good as mechanical cleaning or they can't clean because of sutures. And then we have your daily active control, and that's for your high-risk patients. That's very low chlorhexidine. Why would you use it? It's obviously 40% less chlorhexidine. So that means you get better taste, more compliance, reduced staining. It's exclusive to professionals, so it's not in retail. The patient cannot self-prescribe, go into a pharmacy, go into a supermarket and buy it, which we think is so important. It should be in your hands, the prescription of chlorhexidine. It's got the widest spectrum of activity, a longer substantivity, and it's a 500 milliliter bottle. If you want to know, I know you guys have come on and you're really eager to hear about the Perio. We're going to get into it in just 1 second. If you want to know any more about Perioade or any other types of products, then contact me. Thank you so much for joining us. I'm now going to introduce the lovely periodontist, Rina Wadia, and she's going to take us through the new scary perio classifications. Here we go.
Thank you, Laura. Thanks for the introduction. Can't believe it, 144 people on a Thursday evening just before Easter bank holiday. That's pretty impressive, especially when it's perio, and especially when it's the new classification. So it doesn't get as bad as that usually, but don't worry. We're going to try and keep it nice and interesting. It is a little bit difficult to interact because it's a webinar, but hopefully you can smile and nod at your screen, and we'll try and get through it together as quickly as possible. On a more serious note, it is a really, really important topic. A lot of people are confused about it. There's lots of confusion, lots of people stressed out about when they have to implement it and all the various components of it. So my aim for today is to make it as simple as possible. I want you to go away thinking this isn't too bad. I actually quite like it, and it's really easy to implement. I was going to say on patients tomorrow, but hopefully not tomorrow, maybe after the weekend. So what do you know so far? And you're probably looking at the screen thinking, maybe not so much. So let's go straight to it. So what we're going to do is go over some of the key points of the new classification. And then we're also going to go through a few case examples. And if you can kind of, obviously we can't interact properly, but if you can do it as we go along, that will be the best way to check that I've explained it properly.
Yeah. Sorry, Rena, just to cut in, I'm going to mark anybody's questions. So don't worry, guys. I'm going to mark them. And then when we have question times, they'll pop up. So just please ask your questions, be free, and we'll get to it.
Perfect. So a little bit of background to start off with. So how did this all come about? And as Laura said, with the products, it's just as with anything you read or anything you say to your patients, anything you use, it's really good to get a background before actually talking about it. So how this happened was there was a group of European periodontists and a group of American periodontists, and they got together in 2017 in the US, and they basically went through all the latest evidence on diagnosis and classification and decided, firstly, we need to update the classification. And then they came up with a consensus, which was agreed by the group, essentially. And that was the sort of the actual new classification. And then what happened was a year or so later, the BSP, so the British Society of Periodontology, then developed guidance based on this classification. And this guidance was used to help UK practitioners, which is probably all of us here, was used to actually help us implement this particular classification. So there are differences, and the first key point to establish is there is a difference between the original classification that was released and then the BSP's version. And we have tailored it, luckily, so it's much easier for us to implement. So just be a little bit careful depending on what you're reading. Just make sure, or lectures you're going to, or things you're listening to, just make sure you know which one is it that you're talking, or that they're talking about. Are they talking about the original one by the EFP and AAP, or is it the BSP's developed guidance? And the BSP one is the one we need to know for UK practice, essentially. So that's the one we're going to be spending today on. So firstly, why did we actually need to update the classification? And you're probably thinking, God, it's another change, another stress that we have to deal with in dentistry. But it has been 2 decades since the last classification. So it was 1999 when the one that we're currently using with the chronic and aggressive, that was made. So it's been 20 years, which is quite a long time. And in that time, things have changed. The evidence base has changed. We've learned more about the conditions. And so therefore, the new classification has been used to develop and accommodate the advances in the knowledge. The other thing is the way we now work, both in medicine and dentistry, it's all about precision-based medicine. So what that means is everything is now tailored to your patient. It's not just about what's in their mouth. So it's, especially with perio, you know, it's not just about plaque. It's also the other things, such as smoking, such as diabetes. So precision-based medicine is tailoring it to your patient and incorporating these risk factors. So this new classification is great for that because it definitely takes that into account. The other thing is there wasn't a classification before for peri-implant disease or an agreed, accepted consensus one at least. So that has been incorporated, which I think is great. And it's going to be a live system. So there's a drastic change from what we have before and now, and that's quite a big leap in terms of the differences. But here onwards, there's going to be lots of little tweaks going forwards. So it's a live system. I would encourage you, if you have any feedback from it whilst you start implementing it, do feed it back to the BSP. They're very open to suggestions, open to things, and you know it can be updated. So that's definitely a good idea if you're having any issues with it. Okay, so with the original classification, you would have seen this table in the paper. And essentially, the first thing we need to establish is there are two major categories, the periodontal diseases and conditions category and the Peri Implant diseases and conditions category. And Laura, can you see my cursor? Is that, yeah, okay, great.
Yeah, I can, yeah.
Yeah, great. So this particular one here is the one that we're going to spend time on, and that's the one that the BSP have given guidance on. So the paper to refer to is the one in the BDJ, and there's several papers. So the first paper goes over the guidance itself, and then the papers after are quite helpful because each of them are case series, and then they essentially go through a case and go through how you would diagnose and classify that case, essentially. So it's worth digging out those papers and keeping a copy of them in the practice. So let's get started with the BSP guidance. So within that bit that was summarised, which is the periodontal diseases and conditions, there are three subcategories. Okay, so the first one is periodontal health, gingival diseases and conditions. The second one is paradontitis, and the third one is other conditions affecting the periodontium. So let's talk about the first one. So this is the first time that we've actually given health a definition. So in the past, if you think about it, what is healthy? We've never really spent time defining that. And that's really, really important because we also, as well as disease, we need a definition for what healthy actually is. So just have a think in your minds, what would you think would be healthy in terms of probing depth, for example? What would be acceptable in terms of bleeding? And I mean, some of you might be saying 3 millimeters, some of you might be saying bleeding's not allowed, some of you might be saying, of course, bleeding's allowed. You know, when was the last time I had a patient with 0% bleeding? Even in a perio clinic, I think it's been a while. So the first thing to say is health in terms of probing depths has been defined as 3 millimeters or less, okay, which is straightforward. And there is a level of bleeding which is acceptable. So less than 10% bleeding is acceptable on a patient-by-patient basis. So if you were probing and there was a site that was bleeding, of course, that's not healthy, but on a patient-by-patient basis, looking at their whole mouth, less than 10% is allowed. And I think that makes total sense because, as we said, how common is a little bit of bleeding? It's very common. Some would almost argue it's less than 10% is what we would say is normal and therefore healthy. So I would say that's the first thing we all need to know is that healthy is 3 millimeters or less, and less than 10% bleeding is allowed, basically. Okay, going on to then the second subcategory, which is the one you're going to be seeing all the time, and it's the one that you need to know inside out, which is obviously parodontitis. So parodontitis, you can see here, there are now only 3 different types of parodontitis. It's quite fun drawing on this, sorry. So there are 3 different types of parodontitis. This one is the one which is basically parodontitis. It's just called parodontitis now. And then the other 2 are necrotizing and parodontitis as a manifestation of systemic disease. So if someone asked you how many types of parodontitis are there are 3, and the second one is the one you're going to be seeing pretty much on a daily basis. So let's go through that. You probably now realized within that parodontitis category, there is no chronic and there is no aggressive. You've probably heard everyone saying there's no more aggressive. Everyone's going on about there's no more aggressive, but not only that, there's also no more chronic. It is just called parodontitis. And why is that? Well, when they looked at the studies and when they looked at all the evidence base, what they found was that chronic and aggressive, to see them as separate diseases, there wasn't that much evidence for that. So what they said was it's more of a spectrum. And on that spectrum, you have the aggressive patient on one end of the spectrum and the chronic on the other. So it's more of one condition on a huge spectrum, and your patient will lie somewhere along that spectrum. The only one where they didn't think that applied to was the localized aggressive periodontitis, so the juvenile one that we used to call, the molars and the incisors. And they thought there was that was a different entity, but they didn't want to, in the classification, make it too confusing and have another category for that. So the way they've taken that into account, which we'll see later, is via the extent. So just remember that. I'll come back to that. So the only other two periodontitis types are the necrotizing and the manifestation of systemic disease. So 3 types of periodontitis. So let's go into actually coming up with our what we call a diagnostic statement for our periodontitis patients. So you've all probably heard about staging, grading, risk factor profile, current disease status, all those kind of things. So it's no longer, you can't just put in your notes chronic perio or aggressive perio. It's a little bit more. It doesn't take much longer, but it is a little bit more. And I've read the paper lots of times, and I think the simplest way of understanding it and applying it is via these 6 steps. And we will share this presentation, and I will share a summary of my slides as well. So don't worry about writing everything down. I'll just email it to you if you want as well. So there are 6 steps, okay? So what we're going to do is spend a couple of minutes on each step, and as long as you go through each of these steps, you'll be absolutely fine. So the first one is determine the type of periodontal disease. The second is determine the disease extent. The third is the stage. 4th is the grade. 5th is the current status, and 6th is the risk factor profile. So let's go through each of them in detail. So the first one is type of periodontal disease. Now, what do I mean by that? So you're asking yourself, is this periodontitis? Okay, and the key sign of periodontitis is bone loss. Okay, so if you saw a radiograph and you saw bone loss, you would say, okay, that's probably a periodontitis patient. So bone loss is the key thing here. So the first thing you need to establish is say to yourself, okay, this is my patient, these are the radiographs. Is this bone loss due to perio? Or is it something else? Like it could be, the other causes, as we see here, are things like crown lengthening, because you're taking away bone, so that would cause bone loss, orthodontic treatment, endoperio lesions, impacted third molars. Especially if you're doing surgical extractions and then removing bone to take out that molar, that bone loss isn't due to perio, it's due to something else. And other things. So the first thing you need to do through your history and exam and asking the patient and using your clinical judgment is this bone loss due to perio? Probably is, okay, on most occasions, but you just need to check that. And if it is, you've basically got your first step, which is it's periodontitis. The second thing is to establish the extent. So here it's divided into 3 categories. It can either be localized, up to 30% of teeth affected, generalized, more than 30%, and then there's another category. Now, this is where that localized aggressive has sort of been taken into account. It's called molar incisor pattern. And if it's molar incisor pattern, it's basically what it says. Your first molars are involved as well as the incisors. But again, this isn't going to be very common. These 2 are going to be the most common. And here, again, you're just looking at your radiographs, okay? So you're still looking at your radiographs, you're still, as well as establishing whether the bone loss is due to perio, you've now said, okay, now how extensive is this bone loss? Okay, so that's straightforward. Then we move on to staging and grading. So once the patient has been diagnosed with periodontitis, this is the next step. With the original classification, it was quite involved. I probably use that adjective. There were quite a lot of things to tick off and go through, and there's a big table. We are very lucky that the Bsp have simplified this. It's super simple. It's based on bone loss again, and you're still looking at radiographs. So how do we do this? So what we do is the first thing is staging. Number 3, step 3, staging. Staging is all about severity. So how severe is this bone loss? Okay, so you've got your patient, you're still looking at the radiograph, and you're asking yourself, how severe is it? That's it. Don't worry about the age, don't worry about anything else, just how severe is this bone loss? And you pick the worst tooth in the mouth. So that means if you've got a patient with 90% bone loss on one tooth and 5% bone loss everywhere else, you go with the 90%. Okay, so it's the worst case scenario. And so you might think, well, that's not very representative. Well, you can then add a few notes to say it's just one tooth, but the key thing is it's the worst case scenario. Now, those with early stage periodontitis, you may not have PAs, okay? So you may not be able to look at the percentage bone loss. So here, use your clinical judgment, and you can estimate. And to be honest, if you've just got a bite wing and you can see the bone, it's likely to be one of the early stages, so stage 1 or 2. But if you can't see the bone, you need to take a PA. So how do we actually stage it? So I would focus on these 3 stages. Stage 1 is almost a tiny little bit of bone loss. Here, stage 2, 3, and 4, what you've done is divided your tooth into thirds, sorry. So the coronal third, if it's affected, it's stage 2. If it's the mid-third, it's stage 3. And if it's the apical third, it's stage 4. So you're looking at the worst tooth in the mouth and you're thinking to yourself, okay, how severe is this bone loss? Is it in the coronal third, mid-third, or apical third? And that then gives you your stage. So again, pretty straightforward so far. The BSP have said that if you have got a patient who you've looked at previous radiographs and they've lost a tooth, and they've lost it due to peri, and that would probably mean that it's in the apical third, hopefully, then you can actually immediately assign stage 4 to that patient. So this is, again, reinforcing you're going with the worst case scenario, essentially. And the stage can't improve. It's always the worst stage. You can't go from a stage 4 to a stage 2. For example, if that tooth's been taken out, you always go for the worst case scenario. Okay, so that's staging. The 4th step is susceptibility, and you're looking at the grade here. So you're thinking to yourself, how susceptible is my patient? So you're still staring at that worst tooth on your radiograph, and all you're doing now is taking into account the patient's age. So in the years that my patient has been alive, how much bone loss have they had? Has it been rapid, therefore they're susceptible? Or has it been very, very slow, i.e. they're not very susceptible? So what you do here, again, is take into account the bone loss, but then you compare it to the age. So the best way of doing this is there's 3 grades, A, B, and C. Okay, so there were 4 stages, 1, 2, 3, and 4, and there's 3 grades, A, B, and C. And the best way I found of doing this is asking yourself a couple of questions. This is the worst grade C, someone who's really, really susceptible. So you ask yourself, is this bone loss more than my patient's age? Okay, so if you've got a 20-year-old, for example, who's got 80% bone loss, that patient is super susceptible because the bone loss is much more than their age. Therefore, they automatically get assigned a grade C. Okay, so that's the first thing you would ask yourself. If they don't fit that, then you would ask yourself, okay, is the bone loss then less than half their age? Okay, so less than half their age. So if they're 50 and they have 10% bone loss, that's less than half their age. Therefore, they're on the other end of the spectrum, which is grade A. And if they don't fit either of those, then it's grade B. And personally, I think that's the best way of remembering it. Is it more than their age, grade C? Is it less than half their age, grade A? Or is it anything in between? So grade B. Now, you can calculate it. I'm not very good at maths, even simple maths. So I prefer those 3 questions. But you can calculate it, and this is what you do. Obviously, the percentage bone loss divided by the age, and it would fit into either one of these grades. Okay, good. So what we haven't done so far is look at pockets, right? Which is, we don't treat bone loss, we treat pockets. All we've done so far is literally stare at your radiographs. You've looked at the radiographs and you've asked yourself, number 1, is this bone loss due to perio? Number 2, how extensive is that bone loss? Number 3, is it how severe is it? Looking at the worst case scenario, and then you've looked at the patient's age and said, how susceptible are they? How much bone loss have they had in their lifetime? So you've literally just looked at bone, and we don't treat bone loss, we treat pockets. So this is where the 5th step comes into account, which is your current status. So you might be thinking, okay, why did we spend so much time staging and grading this patient if we don't treat bone loss. Why is it important? And the key thing is, it is a reflection of historic disease. And regardless of whether a perio patient has pockets or not, if they've ever had bone loss due to perio, this is the key thing, they are a periodontitis patient for life. So you've labelled them as, you are a periodontitis patient, therefore I need to keep a closer eye on you. I need to see you for maintenance, lifelong. I need to keep a check to make sure you don't relapse because it's a chronic condition. So it's if you weren't to put that label, even if the patient was stable at that present state, they would probably relapse. So it's just a way of saying you're a perio patient for life, and we need to take that into account, basically. So, okay, how do we look at the current disease status? Well, we have obviously our pocket chart now. We're looking at our probing depths, we're looking at bleeding. So this is where you now have 3 options. The first option is if your patient is, there's no, what I call open, I'm going to use the terms open and closed pockets, which I think is a great way of actually explaining it to your patients, because sometimes they don't really understand when we're talking about 6mm pockets and getting it down to a 4 and an 8mm pocket, it can get quite confusing. So a really nice way I've found of explaining it is to say to a patient, you have an open pocket, and an open pocket is anything that needs treatment, i.e. 4mm and bleeding, or 5 and more, right? And a closed pocket is anything that has been treated and is essentially what we call maintainable. So for without bleeding after treatment, or less than that, essentially. So what I would say stable is no open pockets, and no bleeding more than 10%. Remember, we're allowed to give a little bit of leeway, you're allowed to have a little bit of bleeding. So that's stable. The other option is disease remission. And the key thing here is bleeding. So they've got more than 10% bleeding, but they do not have any open pockets. Okay, so there's no open pockets, it's just bleeding. So they're in remission, they're starting to relapse essentially, and you've got to catch them quickly before they become unstable, which is when they've got open pockets and there's bleeding, and obviously that needs treatment. And probably when you first see the patient, they will be unstable. You're probably starting to gather that this model, this classification model, is based on the oncology model, because words like remission, stage, grade, it's all derived from that. So just to give you a bit of background, that's where they modeled it from. Good, so that's your current disease status. We've spoken about closed and open pockets. And then this is, if you have a look in the paper, you might have seen this. This is the diagram, which basically is trying to say that classification just relates to periodontal health, gingivitis, and stage and grade. So it's just stage and grade. Diagnosis is when you add in the current status, okay? And then there's one more step actually after this, which is called the diagnostic statement. And that's what we need in our notes, the diagnostic statement, because that takes into account your 6th and final step, which is your risk factors. So this is a completely new way of introducing or using risk factors within your actual diagnostic statement, but I think it's brilliant because it really makes you think about it and bring it into your treatment plan. So number 6 is considering whether your patient has any lifestyle risk factors. And this is anything that can be measured, controlled, changed, and it's just a lifestyle risk factor. So what it isn't is poor oral hygiene, irregular attendance, high stress levels. They are all really important risk factors, which I'll go through. But in here, we're mainly talking about, really just talking about 2, smoking and diabetes. And it also includes ex-smoking as well. So you can actually include that. So whilst we're on risk factors, and whilst you've given up your time to talk about perio, I just wanted to get a few more little bits in. So now we're going to take a sidestep to just spend a bit of time on risk factors and just updating our knowledge on this, because I think this is quite important. So a risk factor is anything that increases the chance of the patient getting the disease. And it doesn't cause it, it just increases the chance. It can be modifiable or non-modifiable. And these are the ones that we really want to focus on, because that's what we can change. It might increase your patient's likelihood of getting perio, how severe it is, and also you might change the way you treat that patient as well. So obviously the key one, and the one that's been included in the classification, is diabetes. And this is absolutely huge. It's a global epidemic, and we would call it a modifiable factor because although it can't be cured, it can be controlled. And control is the absolute key thing when you're considering diabetes, because if their control is good, then their risk is actually the same essentially as someone who is healthy. So it's all about control. So let's go through a little bit about diabetes. I'm sorry the text has come up in one go. This software doesn't allow us to do it bit by bit, so just follow me through if you can. So the first thing about diabetes is that obviously they might be at risk of hyperglycemia. So take that into account. If you're doing lots of perio treatment, like half an hour at a time, book it in, at a sensible time in the morning after breakfast, after lunch. Make sure the patient's eaten, basically. The key thing, as I said, with diabetes is the control. And the way we measure control is the HbA1c level. Because when you ask your patient how well controlled they are, and you just say, oh, you've got diabetes, probably your next question is what type is it? And then you'll say to them, okay, how well controlled it is. I am sure they will say it's very well controlled. They all apparently are very well controlled. So the only way you'll know is by asking the HbA1c level, which is a measure of the last 3 months of how well controlled they are. So it's worth asking them. They may not know. It's worth asking their GP, especially for severe perio. I always have that in my notes, because the thing is, if they're not well controlled and you're doing treatment and it's not working, and you think it's due to their plaque control, you think it's due to your treatment, who knows? You may miss it's actually because of the diabetes, and that's important to pick up. So for diabetic patients, you might be seeing them more frequently. You do need to warn them if they are not well controlled, then it will reduce the success of their treatment. You don't need to give antibiotics for them, and definitely always be a supporter, because I'm sure you know at least one person with diabetes, and they have so much to think about. Right? Can I have this to eat now? Have I had my medication? Have I been to my eye appointment? Have I been to my diabetic foot ulcer appointment? There's so much to think about. So it's important to, when you're talking about plaque control and managing perio, to really support them. Find a way, I know you've got a lot to think about. Let's try and find a way we can make this work in your regime and support them. And then the final thing with diabetes, which is quite interesting to know, is an improvement in the glycemic control, the HbA1c level, which we mentioned, can be achieved through successful periodontal treatment. Now, this figure here might not sound like a lot. 0.4%, it's not even 1%. Does that really make a difference? And the answer is yes. It's really significant, although it doesn't sound like a lot. You can see the stats here, but also the best way of explaining it to your patient is it's equivalent to them adding another drug in their regime. Okay, so it's almost like saying to your patient, I know you're not very well controlled at the moment, but you know what, if we can do some really good perio treatment, we can probably improve your diabetes control. Possibly to the extent of adding another drug to your regime. You may not need, if your GP is considering giving you that metformin, maybe you might not need it. It's really motivating for patients if you can go through these things. So that's diabetes. Other risk factors which aren't in the actual classification, but should still be in your notes and should still be taken into account are things like immunodeficiency. Okay, so we're talking about necrotizing diseases, AIDS, HIV. By the way, it probably won't look like that, because what has changed is the medication. Medication is amazing now. You don't know who has HIV and who has AIDS. It won't be as apparent, but you might notice subtle signs of necrosis, pseudomembrane, halitosis. So be very, very vigilant, basically. This is an interesting risk factor that was discussed on one of the Bsp conferences. It's really interesting. It's all to do with inflammation. Now, I'm not suggesting you to, ask your patients if they're make an observation of their obese and then give them diet advice. I personally don't do that. Although it could be argued, because some people say we give smoking cessation advice, we give diet advice. Why can't we give weight advice? I don't know, and maybe things will change. But it's just something to bear in mind and keep up to date on. And other things, risk factors like pregnancy is a risk factor, essentially. It changes the hormones in the body. The way I explain it to patients is that their gums just become a lot more sensitive. So before, they could get away with not using floss or interdental brushes, but now, even just missing it for one day, your gums will start bleeding. So you can't get away with it now. And there's two different types of changes that they might get. You might get edematous changes. So this is when I'm sure you've got experiences when you're probing the patient and it's just profuse bleeding really readily, or proliferative, so an epilus is a fibrous kind of change. So keep a watch out for that risk factor as well. These are great leaflets. They're free to download from the EFP, which is the European Federation of Perio website, and great to give, especially to your patients, because I found a lot of patients are worried about having treatment during pregnancy, and it's actually really, really important they do, and it's safe. It's actually more risk not treating them. So this is worth having a look at. And then finally, other medical risk factors are things like medications. We're talking about things like phenytoin, cyclosporin, amlodipine, nifedipine. All these things are going to lead to, it's going to lead to gingival overgrowth. This is a tricky situation because no way are you going to get an interdental brush through here. And if you don't, you're going to get more plaque buildup. More plaque buildup means it's going to overgrow. It's even more difficult to clean, so it's a bit of a nightmare. So you want to, if they do have any of these medications, then try and prevent it from looking like this. So be really, really stringent with the oral hygiene regime. And genetics, thinking about family history, genetics, does it play a role? Yes, definitely. And I say to patients, perio is quite an unfair condition. Some people get away with not cleaning their teeth and they're absolutely fine. And some people are really, really vigilant with everything and they still get perio. So genetics does have a role. So the other risk factor, which is a social history now, we're talking about smoking, which is in the classification, is just as important as diabetes. Smoking, again, has reduced over the years, but it's still fairly common. Smoking is bad news for perio. It increases the patient's susceptibility. It increases the severity. It doesn't help in terms of treatment. Your treatment's less likely to be successful. And even if it is successful, they have a higher chance of relapsing. So smoking cessation is a really good idea and a really good thing to really push as healthcare professionals. This is a great website. It triples, getting help for stopping smoking will triple your patient's chance of stopping. And I think that's a really important statistic to actually say to your patient, because if they're thinking, oh, I'll try myself as well, I'll just cut it out completely, say to them, well, you know what, it might be worth you actually getting some help with this, because it will make it more successful. Cutting down has little benefit, apparently, and this is where I'm talking about cutting down from like 20 to 15, like small amounts, because what will happen is people end up smoking harder on the cigarettes than they do smoke. So that's why that's there. If they do continue to smoke, of course, it's the patient's choice. Just warn them that the treatment won't be as successful, and you do need to put it in your notes, as well as explaining it to the patient. Okay, so your next question to me would probably be, what about vaping? Does that have a role? Do I need to include it when I'm considering parodontitis? Well, firstly, you definitely need to ask about it, and 1 in 5 of your smokers will vape. So I personally think it should be part of our medical history form. If we're asking about smoking, we should also be asking, do you vape? So there's 2.8 million people vaping. I did my master's project when I did my specialty training on e-cigarettes, so I learned a little bit about it. So there's 3 types of 3 generations: first, second, and third. This is pretty much, not many people use these now. This is the most common one, which is second generation, and this one, if you're super cool, you have third generation, which means you can adjust all sorts of things. There are 5,000 flavors last time I checked, and there are thousands of brands. So one of the biggest problems with doing studies on e-cigarettes, and the reason why we don't have that much data on it, especially for perio, is there are just too many different types of products and too many brands, too many flavors. It's very difficult to perform good studies. But what we do know is apparently it is better for your general health. But we don't actually know the effect on periodontal health. or the mouth in general, quite frankly. So my line with vapors is, okay, you're vaping. Are you vaping to help you stop smoking? If you are, great, that's good. But long term, you definitely need to think about vaping cessation. And I put vaping cessation as part of my treatment plan. I think it's just as important because we just don't know. It is likely to have some effect, in my personal opinion, because it's still got nicotine in it. Stress is a risk factor as well, which you might want to put in your notes, although it's not in the classification. Time and time again, I've seen it where patients have been on maintenance for 3-4 years, and then I see them, they've been stable, absolutely stable, for a good few years, and you see them again, do the pocket chart, and literally everything's relapsed. And you put the chair up and you say to the patient, oh, hold on a minute, something's not right, has something changed? And they'll say to you, oh, yeah, Rena, I'm going through a divorce, moving house. There's always some sort of negative life event. And that's stress. And stress has a huge, huge impact on perio. And it's important to bear that in mind. And finally, as a risk factor, diet or nutrition. Again, keep that at the back of your mind. And there's also brilliant studies by Professor Ian Chappell on diet and nutrition worth reading about. So, before even just looking at smoking and diabetes, we also now know there are lots of other risk factors, although they're not as part of your diagnostic statement, okay, because you're only looking at smoking and diabetes. The rest of them, I think it's important not to forget about them. And you put them in your notes and you discuss them in your treatment plan, because they are also important. So I thought I would just update you on those. So back into our main part of our presentation, which is the classification. We've now covered 6 steps. Okay, so the first step we asked ourselves, is this bone loss due to parodontitis? Is it parodontitis? What's the disease extent? Is it localized, generalized, molar incisor? What's the stage? Is it stage 1, 2, 3, or 4? What's the grade? A, B, or C, that being the worst, most susceptible, and that being the most severe. Then you look at your pocket chart. Is it stable, unstable, in remission? And then you take into account those risk factors. And the 2 key ones in our case is to look at smoking and diabetes. So in your notes, and by the way, this is the slide I would kind of copy into your notes. You can do checklists and tick boxes if you're on SOE or R4, but I have actually just used this text in my notes, and then I delete it as appropriate. And in your notes, how it should look is like this: diagnostic statement, colon, and then essentially statement, generalized periodontitis, stage 4, grade B, currently unstable, etc. So it sounds like a lot, but if you just go through those 6 steps, it's actually not too bad. And it doesn't take, I've been doing this since it came out. We're doing it on clinic with other hygienists, and within kind of 20 seconds, maximum, we're at the diagnostic statement. So it's all about practice and keeping it logical and simple, essentially. So we've got various points within the presentation where we'll have questions. So you're probably sick of my voice, so I'm going to stop for 5 minutes. So if you've got any questions just up to what we've gone through so far, because we'll have a chance for other questions after, just type them in the box, and I'll go answer them as many as we can.
Cool. Hi, Rena. So I'm going to just publish some of the questions that I put to the side. So here, let's publish this one. So it should be...
Okay, so Amit Palmer, thanks for your question, which is, can you also relate each classification to the required intervention? So this is a really good point. One thing to make clear is what we're not doing is changing the way we treat our patients. We're just labeling them slightly differently. So however you have been treating perio, however we treat perio normally, that still applies. So what I'm saying is just carry on treating perio as we're treating perio. It's just the label that has changed. And you don't determine the success of treatment through your staging. Remember, that's just telling you what type of periodontitis patient they are. You're determining your success of treatment through your current status, through your 5th step, i.e., do you have any deep pockets? Do you have any bleeding? That's how you measure success. So I hope that answers that. So Matri, you said about the wisdom teeth. Sometimes wisdom teeth suddenly go loose and are lost. Well, and the rest of the teeth aren't so bad. So that was my point. That I was saying that if the bone loss isn't due to periodontitis, then you don't include that. Essentially, that's something separate. So that's that. And then Saja, if it's the first time you see the patient and they have previous RADs, do you diagnose them from RADs before checking the BPE? So if you have existing radiographs, you can use them. If it's indicated that you need updated radiographs, depending on what you find, so for example, you redid your BPE, you got 4s everywhere, it used to be 2s and 3s, you might then take further radiographs. And then at that stage, you go with the most up to date, and you go with the worst case scenario. So it depends. You may or may not need further radiographs. Constanaza, in remission, are 4mm pockets and bleeding allowed? As you mentioned, no open pockets. Right. So in remission, as long as there's less than 10% bleeding, but you don't, if I go back to the slide, 4mm, the rule that we, I'll just show you the slide, the rule that we use currently still applies. So recurrent gingival inflammation, so that's a key thing, at sites with less than 3mm or greater than 4. So as I said, if it's bleeding and it's 4mm, that's an open pocket, that needs treatment. That will come here, essentially. Okay. Okay, so Ayesha has asked if you've got a 6mm pocket and no bleeding on probing, would you treat that pocket or only do so if the pocket is bleeding? Okay, this is and with the whole thing in this classification, you still have to use your clinical judgment. My opinion is if you have 6mm pockets, if it's a recent 6mm pocket, you need to do everything you can to try and treat that. That might involve referring the patient. If you've got a 6mm pocket in a patient and it's been 6mm for 20 years, that would probably be classed as a stable. And in your classification, it wouldn't be, but in your notes, you would make a note that this is a stable patient. So the Bsp Guidance, if you read the paper, what they've said is you still need to use your clinical judgment. And as you are right now, then decide, do I actually need to treat that or not? But in the first instance, any open pockets do require treatment if they're unstable. Okay, and what about pockets distal 7s? Okay, we've answered that. Sajid, good point about localized and generalized being the same as the old classification. Well, not really, because in the old one, firstly, sometimes people use sites rather than teeth, 30%. The 30% boundary is the same, but here, remember, we're using radiographs largely, whereas you could have mainly based it on a pocket chart before. Okay, BP I'm going to come to, so that brings us on nicely to the next section. And just want to do one more question, which is about bite wings. And as I said, if you can see the bone, that is diagnostic value. That's absolutely fine. And you use your clinical judgment on which stage it is. It won't be very unlikely to be stage 3 and 4 if you can see the bone on a bite wing. Do I still need to do a BP? Right, let's go into the BP because there's lots of BP questions. So great questions so far. Perfect. So BP, nothing has changed with the BP. So now that the classification has changed, a lot of people are getting confused and saying, oh, everything's changed. Has the BP changed? Has referral guidelines changed? So far, it's just the classification that has changed. So your BP is still being used, obviously. It's a screening tool. But it would be of limited value in patients who have already been diagnosed with periodontitis. So what we're saying here is if your patient is clearly a periodontitis patient, you probably want to do a full pocket chart. Because if you don't, for example, you're using a BP on a patient with a history of periodontitis and there's no BP scores of over 2, you would wrongly result in the provisional classification of periodontal health or gingivitis. If you don't do a pocket chart, you will miss the bone loss. You won't call them a perio patient when they are. So what the BSP is saying is, if you have a perio patient, i.e., for example, someone comes to you and says, I've been seeing a specialist for 5 years, or I've been having treatment in the hospital for 10 years, or I've had lots of perio treatment with my dentist, you probably would need a full pocket chart, so you get a better idea of that periodontitis patient. And then, the guidance with the BP in terms of taking radiographs remains the same. And the current guidance is, if you have a BP of 3 or 4, you are likely to need some PAs. The way I do it is, if you can see the bone and there's no other symptoms or so on, you're probably okay with bite wings. If you can't see the bone on a PA, usually happens on perio patients, upper 7s, just edging off you can't really see where it finishes, take the PA. Because you'll be so surprised sometimes where the bone actually ends, and that will change the way you treat that patient. With the BP, whilst we're on the BP, if you don't mind, just want to briefly touch on the fact that there were, a few years ago now actually, that there were 6 changes that were made to the BP. So I'm sure you know this, but I just want to touch on it. The first change was, if you get a code 4, you need to examine the rest of the sextant. What we used to do in the past is, if you get a code 4 in a sextant, you would just move on to the next sextant. So for example, if I was probing here, right, and I went here, and then I got a 4 here, it's a really deep pocket, I would move on to the next sextant. But what would happen if you did that, you'd miss this furcation involvement, and the furcation involvement is a star. So if you'd stopped here, you would have just got a 4, but if you carry on, you get a 4 star. So basically just probe everywhere, so you don't miss anything. The second stage was, if you get a code 3, it's important to actually not jump into doing a pocket chart straight away. And you do something called risk factor control. So you're giving OHI, you're doing a gross scale, you're talking about smoking cessation, anything that the patient can do to help themselves, to help treat their condition. You then close off the course of treatment, and then you get them back again, then you read your BP. 8 to 12 weeks later. If it's still a 3, which it might be, then you then do your pocket chart. If it was a very mild disease, so 4 or 5 millimeters, you'll be surprised, and I'm sure you've seen this, where even just by oral hygiene, you can close the pocket. So that's an extra step that was introduced. The other thing that they emphasized when they made the changes was that it's important not to use the BP around implants. Hopefully you don't see too many patients like this, but you can't use the same measurements around implants. Implants are different, the tissues around them are different, so you need to probe a 4 or 6 point pocket chart around them, not a BPE. Radiographs we've touched on now several times, so take the appropriate radiographs. You only need to now record 4 millimeters and above on your pocket chart, and that hopefully should save you some time, but you definitely need to record bleeding. Bleeding is a measure of active disease, bleeding coming from the inside of the pocket, so that's always important to include. So that's the BP. It hasn't changed, but it's important to be aware of the kind of up-to-date guidance on it. The other thing which hasn't changed is referral guidelines. And these remain the same. Again, I would urge you to have a look at the BSP website on this. The one you need to know is this one, which is complexity 3. So any patient who has a BP score of 4 in any sextant, as well as an additional risk factor, should be offered a referral. And this, okay, and again, have a look at this in your own time. I'm not going to bore you with all the details, but these are the criteria. So for example, okay, if you had a patient with a BP score of 4 plus diabetes, you did a round or 2 of treatment, they weren't responding, technically they should be offered, the guidance is they should be offered a referral. So it's important to bear that in mind. And my experience with referrals is, and this is medical legally, Peri was at the top of the game. 3/4 of claims are due to perio or implants, and there's 2 reasons to be litigated against: failure to diagnose and failure to refer at an appropriate time. So if you're ever unsure, it's better to refer earlier rather than later. Of course, there are the complexities with, if you're referring on the NHS, acceptance into hospital criteria and so on. So you have to possibly look at other options, but the key thing is minimize any delay, because patients, you think they don't care until they realize they have to lose that tooth. And they suddenly will switch on you and say, hold on a minute, you told me that you didn't tell me how severe it was, and all these other kinds. I've seen it because I'm on the other end. I have patients in the chair literally crying on a weekly basis, hopefully not because of me, but because they didn't realize that peri led to tooth loss. So always emphasize that with your patients. This is a flowchart that's in the paper, but in the BDJ. I quite like this one, which the Bsp have produced. It is available online on their website. And this is the one that I would say you need in your surgeries, because it goes through, in terms of incorporating the BPE, it goes through the staging and grading, and that would be great to have in each of your surgeries and work through every time you have a patient. And this side is basically what I went through with the 6 steps, or you can use the flowchart. Either is good. So keep that at hand. So now I just want to see if you've remembered everything, and hopefully you have. So we're going to go through a few cases. Okay, so you've got a 49, so the key things are, you've got a 40, there's 3 cases, this is the first one. 49-year-old female. She's got diabetes. She's had some course of treatment with her dentist. And this is how she looks. How they look is kind of irrelevant to the diagnostic statement, but it's just trying to brighten up the presentation. And this is the pocket chart. So what you can see are there's lots of deep pockets, okay? There is lots of bleeding, and there's furcation involvement of the molars, okay? And these are the radiographs. So let's do this step by step, okay? So we're going to go through the 6 steps. Number 1 is this. I want you to kind of shout at me at the screen. I'm going to pretend I can hear you. So number 1 is this parodontitis. Yes, good. So it is parodontitis, that's your first step. Number 2, is it generalized or localized or molar incisor? Yeah, generalized, good. Thirdly, which is the worst tooth? So I'll give you a couple of seconds. Have a look at the whole mouth. Because you're going to pick your worst tooth. Which is the worst tooth?
Come on, everyone, get commenting. Let's see who gets there first.
Tracy. So yes,
Nice,
this is the worst tooth. Upper right 5. Actually, looks even worse here. Probably, how much bone loss would you say that has, roughly? Approximately.
Tracy's on it.
Great, I agree, 90%. Okay, so, I just realized I can change the color. Why did I use green? Okay, so we're dividing the root into thirds, okay? Is it your coronal third, mid-third, or apical third? That's your apical third. So that's stage 3, essentially. Then we ask ourselves, how old is the patient? Stage 4, sorry, not stage 3. How old is the patient? So they're 49, so the 4th step would be, is the bone loss more than their age? Yes. So they're the worst grade you can be, which is grade C. Okay, that's the grade. Then you look at the current disease status, which is step 5. Are they stable, unstable, or in remission? They're clearly unstable because there's pockets everywhere. Great. Then you look at risk factors, the 6th step. Do they have any lifestyle risk factors? Yes, diabetes. Great. So literally how that would look on your notes is you'd say, these are the steps. It's parodontitis, it's generalized grade, stage 4, grade C, currently unstable, and diabetes as your risk factor. So that's how it would look in your notes. So it's not too bad, I think, if you go through those steps. Okay, another one. 37-year-old patient complaining of bleeding from her gums and when she's brushing, biting into hard foods. She's fit and well, never smoker, low stress levels, family history of perio. So she's 37. This is how she looks. So not very inflamed, pretty good oral hygiene levels. And this is her pocket chart. So I did the BP and I got lots of 4s. So that would trigger me to take a full 6-point pocket chart. And what you can see is deep pockets affecting the molars, the premolars, the incisors, and bleeding associated with those areas as well. And these are her radiographs. So let's do it again, step by step. So number 1 is this parodontitis? Yes. Okay, clearly is periodontitis. Number 2, is it localized, generalized, or molar incisor? So have a look at the radiographs. I would say that's localized, right? Then you pick the worst tooth. Which is the worst tooth in the mouth? I would focus on the PAs. Which would you say is the worst one? Very good. Okay, so lower left 6, correct, is the worst one. How much bone loss? Wow, I shouldn't have put that over the root. It makes it more difficult for you. But how much bone loss would you say that has in the percentage terms? Roughly, yeah, agreed, 50%. 50% bone loss. So in terms of stage, is it in the, you'd ask yourself, is it in the coronal third, is it in the mid third, or is it in the apical third? And this is the mid third, so it's stage. Which stage is it? Yeah, perfect, stage 3. Great, so it's stage 3. Now, still focusing on that, we take into account the patient's age, which was 37, okay? So she's 37-year-old. Is the bone loss more than her age, is my first question. Yes, it is. Therefore, she's the worst grade you can be, because she's very, no, not B. She's, yeah, C. So she's, the grade is the highest it can be because the bone loss is more than her age, and therefore it's grade C. Perfect. Then you look at the pocket chart. Is she stable, unstable, or in remission? Great, so she's unstable. So great, she's unstable. And then the final point is, does she have any lifestyle risk factors? So have a think about this one before you type. Any lifestyle risk factors? Good. Okay, some people will get caught out here and say, oh, but she's got a family history of peri, that's a risk factor. It might be, but it's not a lifestyle risk factor. It's not one that you can measure. It's not one that you can change. It's not one that you are going to include, essentially. Perfect, brilliant. So that's periodontitis. It's localized periodontitis, stage 3, grade C, currently unstable. You kind of, if you want to, you can write no relevant risk factors, or you can just leave it. You don't need to write anything there. Perfect. Okay, third case. You've got a 52-year-old female. She's been having treatment in the hospital for 8 years. She's a previous smoker. She used to smoke 20 cigarettes to 30 cigarettes a day, and she's medically fit and well. Okay, so 52-year-old. And this is how she looks. Okay, pretty uninflamed, very good oral hygiene levels. And this is her pocket chart, a little bit fuzzy, sorry, but she's got no open pockets. She's got a little bit of bleeding here and there, but it is less than 10%, okay? And these are her radiographs. So number 1, is this periodontitis? Yes. Thanks, Amit, for the quick typing away. So number 1, it's periodontitis. Number 2, is it generalized or localized, looking at the radiographs? Very good. Generalized. Good. Then, which is the worst tooth? Step 3, pick the worst tooth in the mouth. Yep. Okay, so that's the upper right 4, which is clearly in the apical third. So perfect, it's stage 4. It's the highest stage you can get. Now, this patient is, let's remind ourselves, 52. So is the bone loss more than her age? Great, grade C, so it's grade C. And then you look at the pocket chart, is it stable, unstable, or in remission? Now, careful here.
I had to answer, I had to get involved.
Okay, this is the key thing. It's less than 10% bleeding. It's less than 10% bleeding, therefore, she's actually stable. You're allowed a little bit of bleeding. So stable. And then the final thing, are there any risk factors here? Lifestyle risk factors. Yes. Yes, so you can include ex-smoking in the diagnostic statement. So this is essentially what it would be: generalized periodontitis, stage 4, grade C, currently stable, ex-smoker. Perfect. So that is it, and hopefully I've kind of helped you to realize it's not too bad. I've come up with the 6 steps is what I use all the time. The flowchart is brilliant. Just use the little tools and the more you practice it, the kind of quicker you get, essentially. So there's one more part, okay, which is, this was the most important part, the parodontitis part, because that's the one which we're going to see every single day. There's one more part on, I just want to briefly touch on Peri Implant disease. But has anyone got any questions right now?
Rena, we've just got a question for one of those cases.
Okay.
Did you determine that localized for case 2 based purely on the bone loss when there was generalized BPEs of 4s?
In terms of recording and so on, don't worry, you'll get a link for that. And
Okay.
you can always email me, I'll send you the slides as well. So any questions on the steps? Okay, great. How often do you do, and thank you for your question, how often do you do a diagnostic statement? So I would say every time you reassess the patient, every time the patient has a checkup, you'd want to do a diagnostic statement, maybe every time you do a full pocket chart. There actually isn't clear guidance on this. So this is kind of the preliminary version that's being released by the BSP. There will be further guidance. But I would say every time anything changes, every time you do a pocket chart, things like that, I would redo your diagnostic statement. Or, for example, you take another radiograph and you notice the bone loss actually now in the apical third, you would then redo it. So you want it as up to date as possible, like a bit like how often you do your BPEs. Any more questions before we do the last little bit? Okay, so I'm part of the working group for the BSP, and I've asked this question, we've discussed this, does the stage and grade change? And it's a great question, and right now there's no official guidance on it. It doesn't get any better, I would say, in terms of the stage. You're always going with the worst case scenario, but I think that the grade can change, but there actually isn't any guidance on this at the moment. So I would say just watch this space and keep up to date with what the BSP, the official guidance is on that. How often do you do a 6-point pocket chart? Do you no longer need to do the BP for a patient? Yes. So if a patient is clearly a parodontitis patient, you could go straight to a pocket chart. A pocket chart is obviously superior to a BPE, so then you don't have to do both. How often do you do a pocket chart? The guidance is at least annually for your periodontitis patients who are stable, or you think are stable. If you're doing treatment, so if you've done some RSD, obviously 8 weeks or so later, you need to do your pocket chart. And then depending on what you find, either you do more treatment or you put them on maintenance. So it depends on where they are in their journey. Aisha, did you determine localized for case 2 based purely on bone loss? Yes, the extent is generally based on bone loss, because if you think about it, if it's based on the pocket chart, if there's no pockets, then you would know the extent. So you're looking always at the first 4 steps, in fact, are based on radiographs. Mobility doesn't have an implication on stage. Stage is purely to do with severity. It's purely to do with the severity of the bone loss. Mobility doesn't come into that at all. Okay, so I've got 10 minutes. So I will have some more questions. It's just perioendo, just one more, is a separate thing. Perfect timing, because it comes into a different category, essentially here. And it's now called endoperio for some reason. But anyway, I quite like perioendo. Anyway, so the other part I want to go over is this one. And I just really only spend 5 minutes on this. I'm almost done. Which is the other category, which is just important to bear in mind. Obviously, it's not one that hopefully you're going to be seeing on a daily basis. It's getting more and more common, but it's not as key to really get to grips with as parodontitis. So I'll just briefly go over this. With implant patients, I would treat them as perio patients. So I would probe, I would visually inspect the tissues, check the oral hygiene, everything you do around a tooth, especially perio patients, I would do around implants. You must probe implants. Those that say you shouldn't probe and it will damage it is not true. And it's really unsafe not to probe them, because if you don't pick up that they've got peri-implant disease, we'll be in serious trouble. And there's lots of litigation on that as well. So firstly, you can probe. You don't have to use a plastic probe. You can use whatever probe you like. Just gently probe around the implant. There's no probing depths which are acceptable around implants. So, you can't say 6 millimeter is unhealthy around an implant. It depends on how it was placed and the various systems. So in terms of peri-implant health, essentially, you want to have a look at the radiographs. You will get a tiny little bit of bone loss as it's healing, but there shouldn't be any significant bone loss. And healthy is essentially like a tooth. No bleeding, no swelling, no suppuration. The tissues look nice and healthy, and the probing depths have remained the same. And this actually is really key. So what you're looking at when you're doing your 4 or 6 point pocket chart is, has that probing depth increased? Has that 4 gone to a 6? Has that 6 gone to an 8? If it has, there's something going on. It's not healthy. If the 6 has stayed a 6 every single time you checked it, that's fine. That could be peri-implant health. And then peri-implant mucositis is when it's basically like gingivitis around an implant, is when there's bleeding. And you're probing and there's lots of bleeding and you think, oh, there's something not right here. This isn't healthy. It's peri-implant mucositis. You may get an increase in probing depth because of the inflammation as well. But the key thing that you won't get is significant bone loss. If you get bone loss, then you're heading into the third category, which is peri-implantitis. And that essentially is all those things plus bone loss. And I think that is kind of all you need to know about that. I would keep it really simple. Just you're either got peri-implant health, you've got peri-implant mucositis, or peri-implantitis. And putting that in your notes and explaining that to the patient is absolutely key. If it is not within your scope to treat it, then that's fine. You refer it, but it is within everyone's scope to be able to diagnose it and let the patient know. It's absolutely key, because the problem about implants is the bone loss around them is rapid. Within months, a patient comes with the implant in their hand, and this is from experience. I've seen it. It's super quick, so you don't have time to miss it. It's a time bomb which has actually gone off. So we have to really stay on top of it. Okay, so just to summarize the presentation now. So the new classification, hopefully I have convinced you, is not too bad. I actually really like it. It's quick, it's contemporary, it takes into account the risk factors. It really makes you think about your treatment plan. You're not changing the way you treat your patient, though. You're just labeling them differently. Clinical judgment will remain the cornerstone of formulating the appropriate diagnosis and treatment plan. So this is not just a black and white thing, okay? We're all clinicians, and we still need to then also take into account our clinical judgment. This is the minimum. This is the kind of framework. If you want to add more information, you want to talk about high stress levels, you want to talk about plaque control, you want to talk about all these other risk factors, you want to talk about other things, but the fact that it's just one tooth that's really severe and the rest isn't, in terms of the bone levels, you can add as much information as you want. But this is the kind of minimum that is expected. In terms of kind of further resources, I would say the BDJ papers are great. From January 2019 onwards, the BSP webinars are absolutely brilliant. So please do have a look at those. You will find the original papers on the EFP website. And then I've tried to do a few summaries of that as well on my website as well. So have a look, and I'll put the key slides up. I think they're up already. If you just type in that / and then just put perio-classification, you'll see the key slides. I would say the next steps are to get going. There is no deadline for this, but the earlier you use it, because everyone's going to have to use it at some stage, so the earlier you use it, the quicker you'll get used to it. And a great way of doing this is if your practice colleagues haven't learned about it or aren't in this webinar, then maybe you can present the flowchart to them, present it, show them what you understand, and then you can all kind of try it out together. And then come back and kind of fully implement it. And use things that will help you. And this is one of the hygienists on my course, Jay, she made, I think this is amazing, she made this little diagram where she essentially uses this as her summary. So my point is, do whatever you need to do to make it easy for you. I use the 6 steps. You might think of something else. Whatever it is, those little tips and tricks, I think, are the best way of implementing it. So I hope you enjoyed the webinar. I can't believe there's so many people on a Thursday evening before Easter. Hopefully you're munching away at your Easter eggs to keep you going. But I hope it was helpful. Final little plug, if you don't mind. Just 2 little plugs. I do run a course for hygienists. If you do want to find out more about it, I run a free introduction evening. So just have a look on the website and let me know. And if you ever need a periodontist in London, then let me know. That's all I'm going to say. If you want to drop me an email, I can send you more information, perhaps visit your practice. But yeah, RW Peri is where I spend most of my life, and we're on Instagram if you want to follow. And lots of patient reviews that you can take a look at. Great. So we've got probably 3-4 minutes. Is that okay, Laura, for questions?
Yeah, go ahead. Guys, if you don't get your questions answered, you can email me at laurabailey@dentacare.co.uk.
Let's just go through a few final questions.
The other thing, guys, while Rena's just having a look, this is being recorded, yes, and we will send it to you in an email tomorrow morning, the link where to find it.
Okay, so let's start off with Jane's question. If you diagnose peri implant mucositis, must you refer? No, definitely not. Mucositis is a bit like gingivitis. It's fairly straightforward to treat in practice. The way you treat it is essentially how you treat gingivitis. So gentle, going over oral hygiene instructions, gentle debridement, and all the standard things as we treat gingivitis. So you definitely don't need to refer that to a specialist care. Okay, so in terms of BP scores of 0 to 2, but marked recession, so the key thing is to focus on bone loss. And if they've got bone loss, that's a periodontitis patient. If the recession is just recession, the interdental papillas are intact, that's not due to perio, that's due to overzealous brushing. And the patient might be predisposed to recession because of a thin biotype. And the position of the teeth in the arch, for example, post-ortho. So that's separate. This is what we're talking about here is pure parodontitis, essentially. Bone loss pockets, those kind of things. Thank you, Tracy. I would love to, but I literally just work at my practice. But thank you so much. That's very sweet of you. Okay, if you see DIPAC, if you see 80-year-old new patient with approximately 80% bone loss, how can you determine the rate of progression without previous history? Because okay, remember, the rate is determined, you're talking about susceptibility here. You're just asking yourself, is the bone loss more than their age? And you're assuming that that's taken into account, risk factors, all those kind of things. So you don't need to worry about previous BPs and previous radiographs. You're just asking yourself, from what I can see now, is the bone loss more than their age? So I hope that makes sense. Thank you, Alison. I'm glad it's less scary now. Good. 1 more minute. Any final burning questions? That's my email. You can email me at any point. Any questions, any Peri questions, just drop me a line. If obviously you'll get the recording. If you just want the slides handout, I'll send that through to you straight away. So just drop me an email. And I can get that through to you, or any other questions. Thank you so much. Really honoured that there's so many people. I honestly thought there would be like 2 people. So I'm really impressed. Hopefully Peri isn't too bad in the end. Good.
I think
Thanks, Serena.
Rena, thank you so much for presenting for Dentacare. You've been fantastic. And thank you everyone for coming on board.
Thank you so much, everyone. That's really kind of you. I hope you have a fantastic Easter. I think, Laura, have you frozen?
No, can you hear me?
Okay,
Hello?
I think Laura's frozen, so I'll close off. I hope you will have a fantastic Easter and bank holiday. What amazing weather we're going to have, so make the most of it. As I said, drop me an email, any questions. I hope that was helpful. Thank you again to Dentacare for organising this. I think it's fabulous that we've got this technology now. We can all sit in our pajamas and watch a webinar. So I think thank you so much for organising it, and hope I'm sure everyone really appreciates it.
Thanks, Rena.
Thank you. Good night.
Thanks. Happy Easter, everyone.